Gunby is also a minister, if you can tell. I think it's important for people to understand that in the politics, in that arena, you see my face a lot. I'm not involved in the business part of the hospital. When we got into this situation and we started looking for experts, after the mediation agreement, Brother Al, I call him now, Al McShirley, the attorney for the NAACP, we still went out and looked for folks that were cutting edge, that were progressive, that understood the new health care law. Because believe it or not, a lot of these big hospitals have managers that are like dinosaurs and they don't want to change what they do. Well, Vidant doesn't understand how to run a small rural hospital. If they did, they wouldn't have went out of business here. They don't know how to do it. They know how to run Greenville, where they do all the stroke surgeries and all the heart surgeries and all the big money, and they can waste money and get away with it. But in a small rural hospital, you've got to run like a small business and be tight. You certainly can't run any business with a half a day a week, which is actually what was taking place. So anyway, it's important also to know that RCH, who specializes in rural health care, they did a business plan for us that showed the hospital standing alone could make money, including building a new hospital. That business plan hasn't just been to Poole and Associates and to Duke, but it's been other management companies have looked at it as well and thought it was very solid. So first off, that original business plan has been found to be solid. And once again, it showed the hospital could break even without an accountable care organization, without an ACO. The silver bullet to healthcare crisis today in rural America is this ACO done right. Because not only do we have a business plan that shows the hospital can break even by itself, but we have this other entity which brings potential revenue to the hospital. Now, Beau Bobbit here is a man who called me last fall and he said, Mayor, don't let them close that hospital. That hospital doesn't have to die. You need an ACO down there. With the ACO, that hospital can flourish. It can do great. Well, we talked to him after about 3 months. I understood what he was talking about. And finally, I got the ACO concept. Beau is a national figure in healthcare. He has set up more ACOs than anybody else in the United States of America. Did you just hear me? Okay. Well, he took an interest in Belhaven because he has a relationship with Dr. Boyette. So he wanted to help us. So he's come down and helped us, deferred all his charges down the road, hoping he'll get paid one day, to help us. To help us set up.
Poor will always be with you. He's tight, I tell you.
And he's not poor. But anyway, he said he could help, and he came out, and he's been helping us. I was in Raleigh a couple days ago, visiting with him for a video we're doing to get the word out to everyone about what we've been doing. And he said his wife keeps saying, she says, why do you keep going to Belhaven? What do you tell her?
She's my girlfriend.
Beau, what do you tell her?
This is my calling.
Yeah.
They need me. Y'all need me.
Thank God.
I'm going to introduce Beau. He's an attorney from Raleigh. He's been in the healthcare field all of his career pretty much, representing most of the physicians. He has a newsletter that goes out to 200,000 physicians every month, and he's a national speaker on ACOs, and he's developed more of them than anybody in the country. I'm surprised at how many people that come about and say, oh, ACO won't work. And here we're talking to the predominant expert in the country on ACO's establishment. He's worked with the federal government, and he's also worked with the state of North Carolina to establish a Medicaid ACO. He's one of the people helping the state do that. So this is a frontline, cutting-edge expert on ACOs. And he's told me that Belhaven is the absolute perfect environment for an ACO. So if you would, Beau, just give us a little bit. Speak up too, Beau. You're kind of quiet.
I love what I do. I've been in healthcare in North Carolina for 30 years, and I realize I'm one of the luckiest people because I get to help noble people help other people. And Dr. Boyette said they're trying to close a hospital. I said, wait a minute, this has been around for 60 years. And we thought, didn't you think that the big hospital said the way to save the hospital is to work with them? So that's why I'm here. But these gentlemen have done a fantastic job. And so I'm not going to repeat that. It's a warm night with a bunch of people, but I want to say one thing. I know ACO. I don't know the numbers on hospitals. I defer to the experts, and you heard about these experts, but I do know ACOs, and I know rural ACOs, and it's going to work. And I actually was talking to the Senior Vice President of Duke this morning at breakfast, and she said, what you need is an ACO down there. I get that part. What happens if you're really sick, though? But let me tell you why this is going to work. And ACOs are designed for this. Now, it's nobody's fault, but the way you do now is that Dr. Boyette or your, if your faith community, your church, you go make sure somebody doesn't have to go to the emergency room, doesn't have to go to the hospital, catches that asthma early, you get nothing, or you get a small amount of money. But let's say they have a heart attack. Guess what? $100,000. By the time you pay the surgeon, the hospital, the rehab, you know the difference. Now, it's one of the, other than the federal government, it's one of the only places where the more money you spend, the more money you make. And we've run out of money as a country, and they said, we got to change things. And then what accountable care sounds fancy, but what it does, it says, as they've done, I like your graphs, by the way, that was good. I got one nit to pick on that, and I'll tell you in a second that, but it says, if Dr. Boyette keeps doing what he's been doing, gets the support of this community, which has been promised, and I'm talking about the churches, the pharmacies, the nurses, and the hospital, if we get engaged, I'm talking about all the way out to Okokoke, we can do fantastic things. And if we get the community involved, joining hands with the healthcare community, and what happens is, as they said, it's a minimum of 50% of the savings. So for every $2 you save, and the inflation rate is roughly 6 to 8%, it was 12, 15%. So this is all very conservative. For every $2 you save, $1 is kept in this community. And the nit I'm picking with you gentlemen is that that's, and you got to, because they're the consultants, and they got to back this up. But the numbers I'm getting every Friday from my rural ACO that started just a year ago is 6.9%. All right, and I'm from Rocky Mountain, so I'm not a big city guy either. I flunked math, that's why I'm a lawyer. But, you know, look at those. If you took, and I'm not going to guarantee that, but I do know with the commitment, the willingness of this hospital to right size, and I just know where low-hanging fruit is in ACO opportunities, and they're here. One of them, the biggest one that we're seeing is the chronically ill, unmanaged, untaken care of person that's in and out of the hospital emergency room. You all know them. Your number's about 5 times the national average. They're ACOs that do nothing but look for frail elderly, and they just thrive on that. And we can find who you are, and we can take care of you. And instead of being $20,000, $30,000, $40,000 a year per person, we can make you healthy or make you healthier and keep the savings here in this community. So I just wanted to emphasize to you that it's a overdue difference. What is it? It's finally American healthcare. Like the rest of us, you got to work hard, do a better job with better quality. The quality's always got to be better. It's not just withdrawing care, but do a better job, work hard, and save money, and you get incentivized. And what we're talking about in ACO is it can be plowed back into the community health resources, but we've looked at this, and what could be more important than to bridge that gap financially to keep this hospital viable. But we can also plow it into more nurses, more outreach, more home visits. It's a very exciting prospect. And the federal government said, I will pay, it was $1 billion. I'm going to pay an ACO like this. That program's over. But the requirements for that were that it had to be a rural area, and you could not have a large hospital. That was a requirement. Because what was happening is these big hospital systems and big managed care companies were setting those up. And by the way, they're not working very well. And then you have necessity. You all want this to happen. And this will make, if it's your hospital, it's your health system, and if we can keep that buy-in, I promise you that everything they said is conservative. And so I'm very excited about being part of this, and I just hope we're given an opportunity to do this.
It took me a little while to understand ACOs. I'll try to explain it real quick for some people that might not have gotten it. Let's say, for example, that the patient population in our ACO, Accountable Care Organization, was 5,000 people. The federal government at 5,000 Medicare patients. So we got 20,000 patients with the hospital. We need 5,000 Medicare patients. And actually, a man named John Lang has been setting up our ACO. He's got physicians from Washington, Chocowinity, Plymouth, all around that would like to be part of our ACO. But let's just use 5,000 people. The government says, okay, 5,000 Medicare patients, retirees, we're going to spend $10,000 a piece on them, we know on average. So those 5,000 people, the federal government says we're going to spend $50 million over the next year on those people. That's what we expect to pay. Then there's an increase put in that for inflation. So let's say it's $55 million total. So the federal government says on these 5,000 Medicare patients in this ACO, we're going to spend $55 million. Well, if by doing outreach, if by having the doctors pay closer attention, if by making sure people are taking their blood pressure medicine, making sure people are taking their diabetic medicine and taking care of themselves, if all of a sudden instead of $55 million, the government looks at their numbers at the end of the year and they spent $50 million, well, that's $5 million of savings. All right, so the new Affordable Care Act with the ACO takes that $5 million and sends $2.5 million of it back to the ACO. Half of the money that comes to the ACO goes to the hospital. So in that case, it would be at $1,250,000 of revenue to hit the hospital that was never there before. Now the people with Pantiga Creek LLC don't even understand that. And they decided to give away a hospital. The next thing they're going to do is try to get a wrecking ball to go over and knock down a perfectly good building. And I'm telling you something, I need some help. Every single one of you in here needs to take a calling to work for this hospital and go talk to somebody. Find who the Pantiga Creek LLC members are and talk to them. Those managers, Brantley Tillman, Deb Sparrow, Darren Armstrong, Lynn Ross, you need to talk to them. They need to listen. Right now we're trying to set a meeting up next week with those managers. And we've got some promissory. We want those 4 managers to come hear what you're hearing tonight and to come on board and let's save this hospital. All right? It's not been a good relationship to this point. They've been listening to Biden. It's time to quit listening to Biden. Biden's taking us down a bad road. It's time to turn a different way.